streaming. Hi students, today we are going to discuss about the application of automated hemogram in tropical fevers. You all know that in our previous class last week we had discussed about the utility of complete hemogram, the basics of an automated hemogram, and what is a 3-part counter, 5-part counter, and all those things we had discussed. What do you mean by tropical fever? Remember, whenever any child is brought with fever, invariably we will be thinking in terms of some common fevers. What are all those fevers? It can be a dengue fever, it can be malaria, it can be typhoid, it can be scrub typhus. So it can be due to any other illness, or it can be due to other non-tropical fever conditions, such as it can be due to pneumonia, it can be due to urinary tract infection, or it can be due to otitis media, or sometimes it can be due to acute pharyngotonsillitis. These pneumonia, urinary tract infection, otitis media, and acute pharyngotonsillitis are bacterial in etiology, whereas your tropical fevers, this dengue, malaria, typhoid, scrub typhus, you can include lepto, or either it can be viral or bacterial, or it can be due to spirochetes. Majority of them are viral or bacterial. Right. So what we are going to discuss right now, before going to that topic per se, you need to know what is the normal total count. The normal total count for practical purposes is between 5,000 to 15,000. Any count less than 5,000 is called as leukopenia, and any count more than 15,000 is called as leukocytosis. Point number one. What is the role of these implications? Majority of tropical fevers are associated with leukopenia rather than leukocytosis, whereas common day-to-day bacterial infections are associated with leukocytosis. Point number one. Second point, whenever you see total count, it should contain differential count. What do you mean by differential count? What is the neutrophilic percentage? What is the lymphocytic percentage? And what is the mixed? We all know that mixed includes monocytes, basophils, eosinophils. For all practical purposes, in majority of labs, we do only 3-part counter, which will give you neutrophil, lymphocyte, and mixed. Based on that, you need to arrive what is the neutrophil percentage, what is the lymphocyte percentage, what is the mixed percentage. For example, let me say the total count of a patient is 10,000. And your 10,000 cells per cubic millimeter, and you can have a neutrophil percentage of 60%, lymphocyte percentage of 40%. From this you need to arrive what is the absolute neutrophil count and what is the absolute lymphocyte count. Absolute neutrophil count means what? So 60% neutrophil, so 60 divided by 100 into 10,000. So how much does it come around? Roughly comes around 6,000 cells per cubic millimeter. So what is the absolute neutrophil count in this case? 6,000 cubic millimeter. What is the lymphocyte count, absolute lymphocyte count 40%. 40 divided by 100 into 10,000. So it roughly comes around 4,000 cells per cubic millimeter. So this is how you arrive an absolute neutrophil count and an absolute lymphocyte count. Right. So then what else you can what are all the things that you can infer from these values? Remember, an absolute neutrophil count of more than 10,000 cells per cubic millimeter is called as neutrophilia. I will say this is called as absolute neutrophilia. That means neutrophil counts are very, very high. Unless otherwise proved, an absolute neutrophil count of more than 10,000 indicates an acute bacterial infection. An acute bacterial infection that can be either otitis media, that is infection involving your middle ear, or it can be due to tonsillitis, or it can be due to pneumonia, or it can be due to urinary tract infection, otherwise known as acute pyelonephritis. Remember, an absolute neutrophil count of more than 25,000 is called as extreme neutrophilic pleocytosis. Extreme neutrophilic pleocytosis. Remember, almost 40% to 40 to 60% of children with this value will definitely have an serious bacterial infection. Bacterial infection. Right. Then what about absolute lymphocyte count? Absolute lymphocyte count. Remember, an absolute lymphocyte count of more than 8,000 cells per cubic millimeter is called as absolute lymphocytosis. Absolute lymphocytosis. What are all the conditions that are associated with absolute lymphocytosis in pediatric age group? Remember, one is pertussis. Any child coughing like anything, and if the absolute lymphocyte count is more than 15,000 is said to have pertussis unless otherwise proved. 2. Epstein-Barr virus is associated with absolute lymphocytosis. The presentation is usually membrane in the tonsil along with hepatosplenomegaly and lymphadenopathy. The third one is acute lymphatic leukemia, the most common leukemia in pediatric age group. Right? So we had discussed about absolute neutrophilia and absolute lymphocytosis and what are all the causes behind this. Then you can ask me the other side. What is the other side? What are all the causes for reduced count? An absolute neutrophil count is reduced, an absolute lymphocyte count is reduced. It is usually again due to some tropical fevers. Let me discuss all those things in the coming section based on case scenarios. Right? Apart from that, apart from CBC, you all know that the most common investigation that we do whenever we see any patient with fever or some other thing is complete hemogram. Right. Apart from complete hemogram, to find out the cause of illness, whether it can be bacterial or viral, we do one more test. What is that called as CRP? What is that called as CRP? What do you mean by that CRP? C reactive protein. A very high CRP, I repeat, a CRP of more than 100 milligram per deciliter is usually in favor of, I repeat, in favor of a bacterial infection. infection. Then you can ask me whether it is due to bacterial infection or something else. It can also be due to some other viral infection. But by and large, what is the role of CRP? If CRP is negative, I repeat, if CRP is negative, it is unlikely be due to bacterial infection. I repeat, so CRP has got positive predictive value and negative predictive value. Positive predictive value means when CRP is more than 100, Keshav, when CRP is more than 100, it may or may not be bacterial infection. May or may not be bacterial infection. So what does it mean? It indicates some form of infection. It can be bacterial or viral. What do you mean by negative predictive value? So a person comes with fever and the CRP is found to be negative or not raised. So what does it indicate? It literally rules out bacterial infection. It means definitely is not going to get benefited by adding an antibiotic. That is why we say CRP negative means no need to give an antibiotic. CRP positive means may or may not be a bacterial or viral infection. So finally, what is the carry home message? Carry home message based on this discussion? Very simple. The carry home messages are total count more than 15,000 leukocytosis. Total count less than 5,000 leukopenia. An absolute neutrophil count of more than 10,000 bacterial infection. An absolute lymphocyte count of more than 8,000 acute lymphatic leukemia, pertussis Epstein-Barr virus. 5. CRP. I means may or may not be bacterial infection, whereas CRP negative means rules out bacterial infection. Rules out bacterial infection. This is the common thing that you need to know whenever you see any child with fever. Okay? Right. Then let's go to this scenario. Based on this discussion, 1-year-old child, 3 days fever, no focus. What do you mean by no focus? No cough, no cold, respiratory rate is normal, no rash, no joint pain, your liver is not palpable, spleen is not palpable. That is called fever without focus. And one doctor had advised a total count, had advised a complete hemogram. In that, total count is 7,000 cells per cubic millimeter, predominantly neutrophil 70%, lymphocyte 30%. So what is the inference in this case? Keshav, what is the inference? 1-year-old, 3 days fever, no focus. Total count 7,000, neutrophil 70%, lymphocyte 30%. Inference. Is it a bacterial infection or viral infection? Look at this. Neutrophil is 70%. Answer. So here I have one more intern who is answering me bacterial infection. So what Keshav is answering? Acute bacterial infection. But the rule is total count is 7,000 and the neutrophil is 70%. So calculate the absolute neutrophil count, 70 divided by 100 into 7,000. So how does it comes? How much it comes? 4,900 only. What is the absolute neutrophil count value that will indicate an acute bacterial infection? 10,000. But look at this. Yeah, the absolute neutrophil count is just less than 5,000. So what is the carry home message? Do not get carried away by looking into this percentage. Always it is the absolute count that matters and not your percentage. Percentage can be anything. But for me, I need to derive an absolute neutrophil count and absolute lymphocyte count to say whether it is neutrophilia or lymphocytosis. That is the carry home message. So please do not do this mistake again. Okay, second case. 1 year old, 1 year old, fever 3 days, cough cold 3 day, cough cold present, total count 15,000, neutrophil 75, lymphocyte 25. So, is it bacterial or viral? So, let's say this is 75% neutrophil into 15,000. So, how much does this comes? 75, 15, probably it will come around 12,000, I think. So you will say an absolute neutrophil count of more than 10,000 is said to be bacterial infection. But remember, my dear friends, whenever you get cough and cold, it is usually viral unless otherwise proved. A combination of cough and coryza is viral unless otherwise proved. In these cases, there is no need to take a complete hemogram. What is the purpose of taking a complete hemogram when you know that this is a viral infection and this is going to settle on its own? But despite that, one doctor had advised to take total count and it turned out to be high neutrophilia. But remember, these are all simple stress response. So these are all just stress response of the bone marrow to the infection. It doesn't mean that neutrophilia in this case is bacterial. So what is the carry home message? Always treat the patient, not the report. Okay, Keshav? Always treat the patient and not the report. That should be the carry home message for students who are listening this session. So case number 1, calculate absolute neutrophil count. Case number 2, always you need to treat the patient and not the lab. It doesn't mean that a child with absolute neutrophil count of more than 10,000 requires an antibiotic. It is not so. Case 3, yes, 2-year-old, day 5 fever, high grade, dull looking, total count 20,000, neutrophil 75, lymphocyte 25. So, look here, there is no cold, no cough. The child is dull looking, the child is having high grade fever. Here, total count is 20,000. So, how much does this comes around? 75 by 100 into 20,000. How much? 15,000. So in this case, absolute neutrophil count is more than 10,000 and the child is toxic, dull looking. Here you can apply the rule of absolute neutrophilia. So in a case of dull looking, toxic child, not playful, an absolute neutrophil count of 10,000 might be due to pyelonephritis, might be due to pharyngitis, pharyngotonsillitis, or it might be due to pneumonia, or it can be due to otitis media. All are bacterial in etiology. All are bacterial in etiology. So, dull looking, toxic, a neutrophil count of more than 10,000 should be think in terms of an acute bacterial infection, and the child should be started on antibiotic without waiting for culture results. That is the carry home. Here, the child is dull, toxic looking, and you are corroborating this finding to absolute neutrophilia. So, considering this background, this absolute neutrophilia should be given importance and the child should be started on antibiotic. Okay, right. Then, case number 4, 10-month-old child, fever 5 days, no focus, total count 20,000, neutrophil 90%, CRP 100. Blood culture is negative, urine culture is negative, but urine contains plenty of pus cells. Can we say this is an urinary tract infection? Yes, no. Let me give you one more clue. Let me say ESR is 100. And let me say platelet is around 9 lakh. So what is the pattern recognized here? If it is a bacterial infection, blood culture must be positive. If it is a urinary tract infection, your urine culture should be positive. Here, urine culture is negative, but urine contains plenty of pus cells. This is called as, what is that called as? Urine pus cells plenty, but urine culture negative. This is called as sterile pyuria. What is this called as? This is called sterile pyuria. Sterile pyuria means your urine pus cells will be plenty. Pus cells will be plenty, but culture no growth. Culture no growth. Apart from that, this case had an absolute neutrophil count of how much? 18,000, 19 percentage. Absolute neutrophil count of 18,000, a CRP of 100, and ESR of 100, along with platelet, how much? Along with platelet 9 lakh. This constellation of finding a neutrophilia, acute inflammatory proteins like ESR and CRP are elevated. Again, your platelet is a acute phase reactant. It is also increased. So this is an acute inflammatory response. This is an acute inflammatory response apart from infection. So again, if you get this constellation of finding, always think in terms of bacterial infection. But here, the culture turned out to be negative. So less likely to be bacterial. So what is the next common thing that you need to consider? So age less than 1 year, high grade fever lasting more than 1 week, neutrophilia, thrombocytosis, elevated CRP. What could be the diagnosis? Let me say it is a vasculitis. Let me say the child is associated with the strawberry tongue. Let me say the child is having peeling of skin. What else you want? Kawasaki disease. So this is Kawasaki disease. Acute inflammatory proteins are elevated along with the neutrophilia, thrombocytosis, and in an young infant not responding to your antibiotic, think in terms of a vasculitis such as Kawasaki disease, and you need to consider IVIG rather than IVIG mean intravenous gamma globulin in this case rather than an antibiotic. So let's come to case 5. Right. This case, 3-year-old, fever 10 days, coated tongue. Total count is 4,000. And absolute neutrophil count 3,000, lymphocyte count 1,000, absolute eosinophil count is 0, CRP is 100. Let me say liver 3 centimeter below right costal margin and spleen tip palpable. Answer? Answer. Fever 10 days, 3-year-old, India, without cough and cold. See, always remember, in India, if fever crosses more than 1 week, whether there is cough present or not. If cough is present, think in terms of TB. If cough is not present, think in terms of typhoid. It doesn't mean that you will always be correct, but 99.99% you will be correct if you apply this rule, because the two most common causes for infections that can cause fever beyond 1 week is typhoid and TB, right? So what are all the clues here for typhoid? Coated tongue is an which can indirectly indicate that the child is having underlying enteric fever. Typhoid is caused by Salmonella typhi, which is a which is transmitted through fecal-oral route. But now, what is the carry home message for my kids? to diagnose enteric fever based on automated hemogram. As I told you already, fever crossing more than 1 week without cold and cough, think in terms of typhoid, particularly if you have coated tongue, a palpable liver and palpable spleen. But how I can interpret your CBC with respect to enteric fever? The answer is simple. So please listen carefully. Very, very simple. Always it is leukopenia. So leukotyphoid means count, even though it is a bacterial fever, it will not be associated with neutrophilia. So total count will be less than 4,000 cells per cubic millimeter in typhoid. Point number 1. Second point, typhoid is associated with absolute eosinopenia. So your absolute eosinophil counts will be less than 1%. It will be usually less than 4%, but in typhoid it will be less than 1%. Apart from that, what else? Leukopenia, eosinopenia. Apart from that, hepatosplenomegaly along with the coated tongue. So the carry home message: fever more than 1 week, dull looking child, leukopenia with eosinopenia is enteric fever unless otherwise proved. Enteric proved. Enteric fever is due to Salmonella typhi. Remember, we don't do Vidal test. Vidal is obsolete nowadays. The serology test is obsolete nowadays. When you consider typhoid, you need to take blood culture and then start your antibiotic. I'm not going to deep into the drugs behind typhoid. Our aim with respect to this scenario is, how will you diagnose typhoid based on your automated hemogram? Okay, right. Case number 6. 7-year-old, fever 4 days, red eyes. Total count 3,300, CRP negative. Hemoglobin is 13 grams. Hematocrit is 40. Tender hepatomegaly. Diagnosis, let me say, in the month of November. Diagnosis. So as he told, what is the diagnosis? Here you have leukopenia, CRP negative, hematocrit is high. You all know that dengue is characterized by plasma leakage. So your hematocrit will be rise. And remember, dengue will be associated with bulbar conjunctivitis. So during rainy seasons, particularly in the month of September to Jan, when you have a child with the fever lasting for more than 3 days and the child is dull looking with red eyes, and if the total count is less than 4,000 and your platelet is less than 1.5 lakhs, less than 1.5 lakhs, along with your CRP is negative, because this is not a bacterial infection, and a hematocrit of more than 38 to 40% is dengue unless otherwise proved. Now you can ask me one question. Total count is less in case of both enteric fever and dengue. And also remember, in enteric fever also you will get mild thrombocytopenia. Sorry, I had forgotten to tell you. Even in enteric fever, you can have a platelet count of less than 1.5 lakhs. The same leukopenia, thrombocytopenia, everything will be there in enteric fever. But remember, CRP is positive in case of enteric fever, whereas negative in case of dengue. That's why when fever crosses more than 5 days and you suspect dengue, remember, dengue will not last for more than 5 days. If dengue cases fever crosses more than 5 days, always think in terms of an other tropical fevers which can mimic dengue. One particular fever is enteric fever in the form of leukopenia, thrombocytopenia. But remember, the elevated CRP in case of enteric fever, negative CRP in case of dengue. Right? So, case 7. What is this case? 10-year-old, fever 10 days, non-toxic child, hepatosplenomegaly is present. Recent travel to Assam. Total count 4,000, hemoglobin 6, hematocrit 18, platelet 2 lakh, CRP negative. What is the answer? Very, very simple. Whenever you get a child with a fever which lasts for more than 5 days, always see whether the hematocrit is low or high. When the hematocrit is low, it is nothing but malaria. The child had a recent travel to hilly region, Assam, malaria. So in malaria, you all know that RBCs are lysed. So your hemoglobin will be low. Your hematocrit will be low. Whereas fever lasting for more than 5 days, and if your hematocrit high means, think in terms of dengue. So fever plus high hematocrit, dengue. Fever plus low hematocrit, malaria. Okay? Thanks. Next, question number 8. 5 years old. Fever 15 days. Is there any cold? None. Is there any cough? None. But look at this. The child is having joint pain. The child is limping along with hepatomegaly and splenomegaly. Look at the count, 30,000. And in that, and ESR is 100. And the differential count is lymphocyte is 90%. That means what? 90 by 100 into 30,000, which comes around 27,000. What is the diagnosis? What is the diagnosis? Absolute lymphocytosis. 3 diagnoses were offered to you. What are all they? Acute lymphatic leukemia, pertussis, and Epstein-Barr virus. But remember, in Epstein-Barr virus, also you will get liver spleen node. In acute lymphatic leukemia, also you will get liver spleen node. But remember, my dear friends, in pediatrics, when your absolute lymphocyte count is very high, along with hepatosplenomegaly, lymphadenopathy, and joint pain in particular, it is always suggestive of blood cancer, that is acute lymphatic leukemia. Joint pain with absolute lymphocytosis is leukemia unless otherwise proved. The next thing, why this joint pain? Because it is due to periosteal infiltration of malignant cells. Periosteal infiltration by malignant cells. And one more beautiful finding is, whenever you have severe joint pain during night, otherwise known as a night cry, no pain will disturb you during night between 12 to 4. If pain disturbs you between 12 to 4, at midnight and early morning, always rule out acute lymphatic leukemia in children. Right. So carry home message. Joint pain, absolute lymphocytosis is leukemia unless otherwise proved. Right. The last case. Yes, the last case. Okay. 5 years old, 15 days fever, no cough, no cold. Right knee pain here also. Here the total count is 25,000. But look here, instead of lymphocytosis, here neutrophils. Again ESR is high, liver is palpable, spleen is palpable. Answer. What is the answer? So this case is characterized by joint pain. You have heard something called rheumatoid arthritis in adults. But in pediatrics, we call it as juvenile idiopathic arthritis, otherwise known as JIA, which is one form of JIA is called as SOJIA. What is called this SO? SO means systemic onset juvenile idiopathic arthritis, which usually manifests with fever, along with hepatosplenomegaly, along with the lymphadenopathy, and you can have serosal effusion. That means a pleural effusion, pericardial effusion, everything. And here your interleukin 6 will be activated, as a result of which neutrophils are very high. Acute phase reactions, neutrophils are very high, platelets are very high, CRP is very high, ESR is very high. Okay, so please remember, when neutrophils are high along with the joint pain, think in terms of rheumatological disorders such as juvenile idiopathic arthritis. But and here your neutrophil count, your neutrophils are high, platelets are very high. Whereas when you have a joint pain with the lymphocytosis along with thrombocytopenia, it is leukemia. So let me write here before concluding our session. So joint pain with fever. I repeat, joint pain with fever. Divide into two. A case associated with very high absolute lymphocytosis along with the low hemoglobin, along with the low platelet. Why is it so? Because your bone marrow is destroyed by leukemic cells. So this is a case of acute lymphatic leukemia. This is absolute lymphocytosis. Whereas when fever plus joint pain. Okay, whereas when you have very high neutrophil counts, along with very high platelets, along with very high CRP and ESR, it is more in favor of juvenile idiopathic arthritis, whether it is lymphocyte or neutrophil, whether other cell lines are affected or not. In both these conditions, CRP will be high, ESR will be high. Right. So almost it is 40 minutes. Thanks for your